Very quickly, okay.
Yes.
Bobby had said to share some pictures and all that. So I
Yes.
have on a PowerPoint. So whenever you give me after some
Yes.
questions, I'll just
Yes.
screen
Yes. Sure.
share.
Yes.
And
Yes. You can do that.
and the
Yes. Yes.
pictures sometimes, yeah,
Yes.
as you
Yes.
know,
Yes.
speak
Yes. Yes. Yeah.
much more
Definitely.
than words. Yeah.
Definitely.
All right.
And before we just begin, like on a personal note, I believe your daughter lives in London, is it?
That's right. Yeah, that's
Okay.
right.
Because
That's
my
right.
daughter too lives in London. That's why I
Oh, is
was
it?
asking that. I
Oh, how
wasn't
nice.
sure.
How nice. Okay. Okay.
So,
She's only studying at the moment. So
okay, where?
she's studying in a music institute, in a music
Wow.
university.
Okay.
Your daughter's settled in London, working here.
Yes, she's settled.
Okay.
She has two daughters of her own.
Oh,
So
okay.
she's settled.
Right.
She's working there. Yes.
Okay.
So,
Okay.
so you must
Huh.
welcome to this special episode of NTB Dialogues, a special CNS series presenting insightful and thought-provoking interviews with those who have spent years in fighting the world's top infectious killer disease, tuberculosis, to accelerate progress towards ending it. Today, we will be in conversation with public health specialist Dr. BORNALI Datta, who is Director, Department of Respiratory and Sleep Medicine and Project Lead of Mission TB-Free Haryana at Medanta, the Medicity, one of India's largest multi-super speciality institutes located in Gurgaon. She is also Honorary Research Consultant at University College of London. Welcome, Dr. Datta. We are indeed very fortunate and proud to have you with us in our show today.
Thank you.
Bornali, can I call you Bornali?
Absolutely.
Yeah.
Absolutely. Please do.
Bornali, we know that finding all TB is the first vital step if we are to end this disease. But we have been missing TB cases, not only among those who take a TB test, and unfortunately, still a majority are getting a microscopic test, but also among those who are unreached. Can you please share your insights and reflections on this?
Absolutely. So I think that is, at the crux of the TB epidemic that we are dealing with. And so there are so many levels of, missing patients. What the prevalence survey told us, the first level of missing patients is that 30 to 40% of the patients are asymptomatic. So, they don't even know they have it. So, that straight away we have a problem because all our algorithms only start with symptoms and then we move on to diagnostics. That's the first thing. Second thing is that they come to us, they do, reach us, and then we fail them because our diagnostics are simply not good enough. And as you rightly say, microscopy has had been the cornerstone a decade ago, but right now it should be replaced by far superior and point of care diagnostics like molecular diagnostics. However, again, the TB report tells us that 22% of the designated microscopy centers still only 22% have molecular diagnostics. So 78% still function on microscopy. So yes, we still have a long way to go because still we replace everything. And obviously it can't be done overnight. We know that because the cost implications are huge. But nonetheless, in a staged manner, we have to do it if we are talking about elimination. And that finally, the very key thing of the unreached. And unreached is, of course, 68% of our population is in the rural areas. And while the primary healthcare facilities, TB, the NTEP is the largest national program, and it has a huge network, a web of DMCs, PHCs, which all cater to TB, but it's still not enough. And it still doesn't go the last mile and reach the patient who is really far out. The second group that we don't reach are the urban poor, the urban, the homeless, the ones in the slums, the ones who don't have IDs, who are not registered, who cannot be tracked, who are migrant, etc. So those are another very key category, who are often described as, being the engine house of transmission because they are vulnerable. They are daily wage earners. They are exposed to, so much of infection, and they have the ability to spread it in the community. So these, I think, are the various aspects of not being able to, or of the missing cases, rather.
Yes, and very rightly you have pointed not only to the rural areas, but also the homeless and those people in living slums in cities like Delhi and other metro cities as well.
Absolutely.
Because Bernali, it was just last week when we went to speak to a homeless person in a shelter home near Loknayak Jayaprakash Hospital. And there, from him, we learned of the Medanta van offering screening and testing in Ramlila Maidan. In 2018, at the India versus TB Summit, you had shared with CNS about Medanta vans that were reaching the unreached back then.
Yes.
I think under the TB-free mission.
Correct.
So can you share more about this Lab on Wheels initiative of your hospital?
Sure. Absolutely. So you're absolutely right. When TB Free Haryana was launched in Mission TB Free Haryana, now we call it Mission TB Free or Mission TB Free India, because we're in multiple sites now. But when we launched it in 2015, the focus was on Haryana, in the rural districts of Haryana. Again, as we discussed, where access was a problem, and X-rays were virtually non-existent in PHCs and CHCs, functional X-rays. So our van would carry a digital X-ray, and then we would reach the respective district. In 2019, we started working with a group called Center for Equity Studies, who are now part of the Public Health Resource Network, and they were doing some excellent work with homeless people in the Yamuna Pushta area, single homeless men, and they also ran what was called a recovery shelter. Now, there are my understanding from interaction with this group who are doing such good work is that there are 200 shelters in Delhi, but 2 of them only are recovery shelters, one for men and one for women. And the recovery shelter basically means a medical center, a medical facility, where they are taking in the people who need treatment, who are given nutrition, medicines, etc. And when they started this work, they realized there were 2 major problems that these people faced. One was trauma, because they did all heavy labor, and fractures and things were common. And the second was tuberculosis. So that's when they got really intensive work on tuberculosis. And we were introduced by, in fact, a common partner, University College of London, and we started sending our mobile van with the digital X-ray for there. And over there, we were doing mass radiology. We just screened everyone with X-ray, because these were what we now call the key affected population. And, there was no need to symptom screen for them. We just do X-rays for everyone. And we picked up a staggering rate of 6% positivity. So after doing the X-ray, the sputum sample goes to the TB center in Loknayak Hospital. And we got, out of, I think, 1,200 screened, we got some 69 positive on Gene Expert at that time. So it was a 6% positivity, which is the highest seen in any cohort in the world. So certainly that has a lot of merit, and I'd be very happy to share some pictures from you for you as and when.
Okay. Now, currently, what equipment do these vans carry? Just for the benefit of our listeners. Yes.
Absolutely. So we started, again, I have it all in a pictorial format. We started in 2015 with a digital X-ray. In 2018, we added a portable Gene Expert, which was called Expert Edge at that time. It was a single module, so not very efficient, but it worked very well for the rural areas, but not so efficient for the urban, where the pickup was much higher. And that's why we started taking our samples to Loknayak Hospital TB Center. Then in 2022, we had AI. We had Cure AI, our own homegrown Indian AI. And just in 2024, we launched our ultra portable. And so we have kept up with the technological changes. And really, right now, these big vans are no longer needed. You can just sit in a car, carry one portable, ultra portable X-ray, one portable molecular diagnostic, whether it is a TrueNAT or Expert or MyLab. There's so many options now, and just reach your point of concern and just do a so-called camp there, and you can do point of care, not just testing but diagnostic confirmation and treatment.
So right now, you are just the samples are being taken to Lok Nayak Hospital, or you are testing there in
No,
your mobile
at the
lab?
moment we are,
Okay.
so see how it has, we had a very big meeting in March for World TB Day. And basically we have this van which just does digital X-ray. And the
Okay.
confirmatory molecular diagnostic is done by Lok Nayak. But now the plan is to have one of, MolBio's, in fact, one of their ultra-portable X-ray as well as a TrueNut machine installed in the large recovery shelter of 200 people. And that will become a diagnostic center which will not only look after the people admitted in the recovery shelter, but all the homeless people who live in the vicinity, which is, in the hundreds. And then we can draw in from all the, the homeless people around that area. And this will serve as a diagnostic center. So yes, then we will shift the entire diagnostics to be within our remit.
Yes. And how many such vans are there now? And again, since you're talking of the future escalation, and also spreading, if it is on your cards, to have this in other states as well.
Absolutely. Yeah, absolutely. So we have 6 vans right now based in Medanta, Gurgaon, of which 5 vans are in Haryana, 1 van is in Delhi. We have already started a project in Lucknow. So that started last year, October 23. So we had a big launch with the principal secretary, and that is now doing urban Lucknow, but the plan is again to scale it. The other 2 places, we already have a van in Ranchi, and we are planning to send a van to Patna and Indore. And essentially, wherever there is a Medanta, we hope to have a van and roll out the TB program in the similar format that we've done in Haryana and Delhi.
Okay, that is great. Because I come from Lucknow, so it's great to hear that. Yes.
Excellent.
Bornali, what has been the public health impact in terms of screening? You have mentioned some of it, but screening, testing, linkage to care, start
Absolutely.
of treatment, and navigating the treatment pathway.
Absolutely. So that's a great question. And we have evolved so much as a program as well, because we've always worked very closely with government, which is the only way to do it, because their system's already in place, and all we are doing is just augmenting or filling some gap that may exist. But working closely with them in Haryana, at least over the last so many years, we've just this is the 10th year that we are doing Mission TB Free Haryana, and we have screened close to 50,000 people, diagnosed 6,500, around that much, and seen them through with treatment. Now, the thing to point out is that in 2022, we launched a cluster randomized control trial, is what we call it. And in this, essentially, we are doing it in a much more systematic manner, where we are doing it's a trial, it's a cluster trial. So we are doing the sub-centers where we are intervening with our van and molecular diagnostics, etc. And there are control centers where we are not. So in that, we have had some excellent results that we have tripled case notification rate. So that is the public health impact of our work, of tripling case notification rates where we have intervened. And we have now recruited community health workers who also, apart from doing door-to-door active case finding with the ASHA workers, they also do telephonic dots. So because video dots was our goal, but rural areas, it didn't work out. They were not very keen on video dots. So we did it with telephone. So just do a simple telephone call and find out whether they have managed or not. So that is how we have kind of, taken it.
A little more on that. Is it helping reduce diagnostic delays, costs involved, for these patients to navigate that entire health system? Because we spoke to many, and even before, like there was a person again in Delhi, he suffered for more than 3 months with TB symptoms, went to the health system, to whichever doctors he could see, and he was he later on says that I got so many tests done, but nobody asked me to get my sputum checked. And before he could actually get the TB test, already a lot of delay had taken place.
Yeah.
So and the cost involved. he got treated for typhoid, nothing helped, and his symptoms are very classical symptoms of tuberculosis.
Absolutely, yeah.
So also reducing diagnostic delays and reducing the time between diagnosis and treatment initiation, at least
Absolutely.
in this
Yeah.
case.
Yeah, absolutely. So see, the one thing we definitely do is reduce diagnostic delay because we have point of care testing. So we test, diagnose, confirmed within that, camp that we do. At the most, it may spill over to the next day, but the patients are still, the attrition is not happened. They're still very much engaged. And we do certainly in Delhi, we working with NDTB Center with Dr. KK Chopra. He gives the first dose on the day of diagnosis. So then you have captured the patient. He's in the system, you've started the treatment, then there's no way that there's going to be delay. In Haryana as well, we were very keen to do that, to give the dose as soon as diagnosis happens. And even though we've not achieved that, but these patients get definitely started on treatment. So I think the simple thing of having a mobile unit or a sort of a portable system is that you are reaching their doorstep. You're not expecting the patient to come miles from, wherever they live. And especially in rural areas, the distances are vast. We have seen for ourselves, and expecting a patient where, the mobility, especially for women, women, they don't have conveyance, they don't have a way to reach you. So in the rural areas, especially, we found reaching the doorstep really works, because in the last trial that we are doing, of the patients who attended, 52% are women. And that is the advantage of taking a diagnostic unit to the sub center or to the village, because the patients have to walk a very short distance, and therefore you're not losing out on that.
Yeah, that's a very important point you have made. That is very, very important. Like going to the people, taking the lab to the people, or taking the tests and treatment to the people, rather than, that is the only way to find them. That's the only way to find them, because actually we are missing them. They are not missing themselves. We are missing them to bring to the
Absolutely right.
system.
And once we say elimination, we can't be sitting back.
Yes,
We are wanting to eliminate, then you have to, door to door is the only way. You have to land up at their doorstep.
yes.
Yeah.
Is screening and testing for other health conditions also in the offing? I know that it's a tall ask. Right now you are concentrating on TB, but with these mobile vans, maybe little more emphasis on so many various other diseases. Is that in the offing?
Absolutely right. Absolutely,
Yes.
Dr. Shobha. I fully agree that, if we have the platform, why restrict to one disease? Let's do as much as we can. And certainly in the rural areas, one of the things, a lot of focus on integrated healthcare these days. And so we are looking at expanding from TB with TB and COPD, because my experiences from the x-rays is that whoever doesn't have TB has COPD. The cough is then COPD. So yes, you're right. That is one of the things. In the urban areas, the problems are very different. So the plan is to go ahead with testing for, again, very commonly existing things amongst these excluded populations, like the homeless people, IV drug users, sex workers, prisoners, etc., to do not only TB screening, but also screen for the hepatitis B, C, HIV. These are, again, very important things which are treatable. We have such good treatment nowadays. So yes, that's a very pertinent point, and the plan is to expand as per the population demand and need.
All right. One more thing I would like you to talk a little bit about is, you said that, yes, it's the same, almost the same day treatment, and reducing those delays. But I had given you that example of that person who took, means basically 3 months before he was advised a TB test. And then there has been, I read a recent study by Dr. Sushmita Chatterjee, which shows that diagnostic delays average 12 weeks for drug-sensitive TB and 14 weeks for DRTB, drug-resistant TB. And offering molecular testing upfront is very important, but eliminating these diagnostic delays, again, are a field where we need to put our attention to, if we are to stop the spread of infection. So your insights and reflections on this.
Yeah, no, absolutely. I think diagnostic delays. So again, I suppose a lot depends on the which part, where urban, rural, how good the healthcare provision is in that area. But also bear in mind that the first point of contact for every individual is not a hospital or a clinic. They'll go to their local doctor, and again, it's your good or bad luck, the level of competence of that doctor, because in the rural areas certainly there is a lot of rural practitioners who still will not follow the exact guidelines as we know and as the government would like us to follow. So I think there is a lot of that. I think awareness, not only amongst the patients, amongst the general lay people, but also amongst practitioners, has to be increased. They have to understand that a person who is coughing, and nowadays, as we know, not even the symptomatic, the asymptomatic as well, we have to keep a very high index of suspicion, because we are endemic. We have 27% of the world's burden of TB, and therefore our radar should be like really focused on detecting it. So I think awareness, a lot more, a lot is being done by the government.
Yes.
We have Mr. Bachchan as our the brand ambassador for TB elimination, etc. But maybe a lot more needs to be done to make people aware, and the provision is there. The patient just may not know how to access it. Yes. So making them aware. There are plans for an app so that a person just has to tap it on his phone and he will know exactly where to go. So I think there's a lot that can be done. Yes. It is not acceptable to have a 3-month diagnostic delay in this day and age.
Yes, and in a place like Delhi also.
It's like Delhi.
Yes,
Absolutely.
in a metro city. Bernali, you were going to show us some pictures or some slides you wanted to share. So please.
Yes, very gladly. Just bear with me 1 second. Okay, I hope you can see it.
Yes, we can.
Okay. So I'll just do a pictorial things over the last 10 years. So this is what we started with. Our first van, it was a van given by Siemens, and Dr. Trehan, as you know, is he is such a driven and motivating leader, and this is the first van he got us, which had mammogram and other things, and we affixed an X-ray and started this. So this is in Revari 2015. So this was the first technological procurement that we had, digital. This is just a simple portable X-ray machine from Allengers, which is an indigenous company. And then we had the digital setup already there of Fuji, and this was the X-ray that we could see then and there. And this made a huge difference to our entire thing. 2018, this was our Gene Expert Edge that came on board. And again, that made our program very meaningful, because of the 10 suspected TB patients from the X-rays of that day. We could do the Gene Expert, on the day and confirm the diagnosis. And then Cure AI 2022, and this is just a picture of what we get from AI, how they highlight the the areas of concern, and we can see that the left lung here is quite damaged with fibrotic lesions or infiltrates consolidation, maybe a thick walled cavity forming, and this they'll give us a score, and the score in this case I think is 0.98, so 98% probability of having tuberculosis. And these are the partnerships. These are the 6 big vans we have right now. And the partnerships have been from other corporate partners. And we are really grateful for this association. RITES has given us 4 vans. Krishna Maruti has given us 2 vans. In fact, we have 7 now, because they just gave us a second van on World TB Day. Hero Motocorp in the future are going to give us 2 systems. RJ Corp has given us, Siemens and Philips, they had given us earlier vans, which have, one of them has gone to Lucknow now, and one has gone to Ranchi, sorry. So this is how this, the vans work. And this is our very latest acquisition of the ultra portable. And we trialed this in Karnal, and we have started work on this. We'll have one in Delhi and one in Haryana. And we'll see how this works. The government of Haryana itself has given one ultra portable to every district, all 22 districts. So I think in the sense of technology, we are making huge strides in diagnostic, and we must we must utilize what we have, because taking this to this is just an empty village plot on which we put it up, and we had a big camp there, because all that entire village, everybody could just walk over and get their X-ray done if they had concerns. And so this is what we have downsized to, from having these big vans, which are actually quite expensive. They take almost 60 to 70 lakhs in making them, having a lead-lined chamber where the X-ray takes place. Then we came down to a ambulance size. Then now we have a car which carries the ultra portable, both the X-ray machine as well as the molecular diagnostic. And as we know, this can even be done on the back of a bike. But this I wouldn't recommend for long distances, maybe just short distances if we need to go in a very safe manner, because obviously the equipment, the ultra portable X-ray is still a very expensive equipment. And, we have to handle it with a great deal of care. So in Haryana, just briefly, this has been our expansion from starting with the pilot in one district in 2015. We've now covered the entire state of Haryana, sequentially many times over different districts. And this is one of our programs for Adopt a District, where we tied up with numerous corporates and encouraged them to take up a district where we would then assist with case diagnosis, help the government. And this is the cluster randomized control trial that I talked about in Karnal. And the blue, this is the sub-center. And the red is intervention, blue is control. And this is where door-to-door with the ASHA workers. And I think this is the way forward. However labor-intensive and cost-intensive it may be, but this is worth doing if we want elimination. And this is the results that we had, where we covered 3.5 lakh individuals, 3.4 lakh individuals, and there were 238 were positive, 14% out of this, cascade, and some more clinically diagnosed, 244 dots, and then we even did contact tracing, and as we talked about, we did telephonic dots. And we had much more women, 52% women, because the distance for 88% was within a kilometer. So these are very important things from the rural perspective, where distances are huge. And we tripled case notification. As you can see, there's the intervention area. And then Delhi. Now, Delhi, I think collaboration is the way forward. As we know, we have the government at the very center of it, and then the other partners must join in as best possible. Civil society partners, we are now working with another group called Humana. CES is not there now. We have PHRN. They are experts in this, in knowing what happens to the people on the street, who are so vulnerable, the key affected population. We offer our diagnostic facilities. University College of London has given us technical expertise and advice. Then TB Association of India, Diagnostics, Medicine Delivery, and of course the state NTEP, both NDTB Center and Lok Nayak Hospital. So the doctor referral and follow-up. And so this is where Medanta fits in with the diagnosis of chest X-ray. And so you can see how vital it is to have all the partners, because active case finding is done by these groups. And the recovery shelters, for the homeless people, they are taken in there, they're given 3 square meals and their medication and kept till the treatment is completed. So there's a huge need to scale this, especially because we may diagnose as much as we want, but till we have ensured that they are cured, we are not going to have any impact on the disease, on the incidence. So this is Yamuna Pushta. This is the area just on the banks where we, deal with, we have the camps. Our van goes and looks after, does the screening for homeless people. So this is one of the places. Then this is a shelter in Bangla Sahib complex where we recently did a camp. These blue ones are all the shelters. This is with the Humana team, and that's our van over there. And then we have in Old Delhi. In Old Delhi, again, that's a key area. We work in the clinic in Pili Koti and done huge number of camps over there. And so you can see that, there's a huge benefit to be getting a mobile system there. And when we station these ultra portable and move from one shelter to another, again, I can see that having such a tremendous benefit to the population that live in that area, who have, who are really very vulnerable, key affected, and they need all the kind of help and all the assistance we can give to picking up. And as you rightly pointed out, not just TB, but all the other illnesses, because these are all, they're all linked at the end of the day. If someone has TB, there's a strong possibility of them also having, any of these bloodborne viruses. So that's something that we have to keep a lookout for. So this is what is key nowadays in every setting, but especially in the urban setting for this kind of key affected population, is what we now refer as a differentiated care model, because everybody needs a different level of care. So there will be those. So we start off, we do mass radiology and then expert. And now we have expert, TrueNut, etc., positive, negative, the microbiologically diagnosed and clinically diagnosed. Now there are 2 forms. Residential treatment is in the recovery shelter, and those they can be healthcare workers who carry out community-based treatment. So this is a model that we are developing going forward. And in our screening in Delhi, as I told you, we had a staggering level of 5.4% in the first round of screening, then 9.4% when we combined it with clinically diagnosed. And currently, what is ongoing, we have a 6.8% prevalence rate, pickup rate. So this is huge in this cohort, and this cohort has to be looked after, that the diagnosis, treatment, everything has to be looked after. And this is what we launched. You can see Dr. Trehan here, Dr. Guleria, Dr. Jaiswal, myself, and the whole Medanta team when we launched our bike with the Molbio ultra portable X-ray. We have union representative. We have someone from Hero Motocorp who are funding the bike and the ultra portable X-ray. And this is the future, really, that we take the diagnostics to the doorstep of the patient. And, I think we have great hopes of what we can achieve going forward. I think that is my last picture. So this is the plan for Delhi, as I told you. In the recovery shelter, we'll station an ultra-portable X-ray and TrueNAT, and this will become a medical facility for the homeless population in the vicinity, both those living in the shelter and those outside. Thank you very much. I'll stop screen sharing.
Yes, thank you very much, and great work you're doing. And as it is, it'll be our combined efforts of all of us if we want to end TB and reach the unreached. And great experience speaking with you, Doctor, and your journey, and taking us through this journey and what is happening and what is doable, and everything is doable when you have the will and the spirit to do. So,
absolutely right. Well, thank you very much for the opportunity to be here. Thank you, Dr. Shobha. Thank you, Bobby and CNS.
I'm not a doctor, so that title belongs to you. And thank you very much, Bornali. Friends, we were listening to Dr. Bornali Datta, Director, Department of Respiratory and Sleep Medicine, and Project Lead, Mission TB Free Haryana, which has now actually become Mission TB Free India, at Medanta Medicity Hospital of Gurgaon, India. Thank you very much. Till we meet again.